Good evening and welcome to the Pacific Spine and Pain Society's training webinar series. This is our first webinar in the series focusing on radio frequency techniques. The webinar will begin promptly at 6:02 to give a few more attendees a bit of time to get all logged in and ready to go. Again, thank you so much for joining us tonight. We will begin the webinar promptly in 2 minutes. Good evening, everyone, and welcome to the Pacific Spine and Pain Society's training webinar series. This is the first session in our series focusing on radio frequency techniques. We are so glad you've been able to join us this evening. We will begin the webinar promptly in 1 minute to allow a few more attendees time to log on. Again, thank you for joining us. We will start in Good evening, everyone, and welcome to the Pacific Spine and Pain Society's training webinar series. This is the first session in our webinar series, and it will focus on radio frequency techniques. Thank you so much for joining us tonight. This webinar does have CME credit associated with the series. We will have instructions at the end of the webinar with how to claim your credit for attending. These are the learning objectives for the evening. And as a result of participating in this webinar, attendees will be able to describe the basics of energy delivery and lesion size with radio frequency ablation, identify indications of radio frequency ablation and describe the techniques, identify indications of radio frequency ablation and describe the techniques. I would like to actually introduce the moderator, Dr. Eric Lee, who is the current president of the Pacific Spine and Pain Society. Dr. Lee, take it away.
Thank you so much. Hello, everybody. I'm really excited tonight to bring you the first in a series of web-based educational offerings from Pacific Spine and Pain Society. I know everybody's suffering from a fair amount of Zoom and webinar fatigue, so I really appreciate you joining us tonight. And since first becoming president of PSPS, I've spoken to friends and colleagues throughout the country, many from California, Alaska, Hawaii, Oregon, Washington, Idaho, Arizona, Colorado, Nevada, New Mexico. And it's been truly amazing hearing all the stories of what everybody's enduring during these times and how they're still trying to do the best they can for their patients. So I'm grateful for the opportunity to work with them and provide a platform, hopefully, where we can help them maintain those high standards. A common theme that has been coming up is how do we support our members in terms of learning and maintaining the high ethics and standards in the therapies we provide to our patients, especially in regards to CME-worthy credit programs. And to that effort, we created this series, which will start tonight with radio frequency ablation. Now, we're extraordinarily fortunate to have a truly spectacular faculty. They're members of PSPS and national leaders, and they just happen to be in our society as well. And so the format tonight is you'll hear from each one of them. First, you hear from Dr. Vafi Salmasi up at Stanford University, who I've had the pleasure to work with on numerous occasions, about the basics of radio frequency ablation and the science behind why we do what we do. Then we'll hear from Dr. Zach McCormick, who practices down in Utah, at University of Utah, and he'll talk about the radio frequency of the spine and the sacroiliac joint. We'll talk then with Dr. Scott Pritzloff up at UC Davis. I've been fortunate enough to, again, work with many labs with him and learned so much from listening to him describe his techniques and made me a better physician today. He'll talk about radio frequency ablation of the major joints. And then we'll talk with Dr. Matthew Smuck from Stanford University as well, who'll talk about discogenic and vertebrogenic pain treatments using radio frequency ablation. And at the conclusion, we'll have a roundtable moderation with several questions and answers from our faculty. And so if you have questions, there's a chat feature on your Zoom webinar that you can submit some of those questions. And those questions then will be answered with the time allotted amongst all the faculty. And so with that, I'd like to thank everybody for spending their time with us tonight. And we'll begin with Dr. Vafi Salmasi.
Thank you very much, Eric, for the kind introduction. And I'm waiting for my slides to come up, and hopefully I can start. Sorry about the glitch. I don't see my slides yet, so I'm working on that.
Vafi, we are looking at your slides on the screen. Are you not able to see them?
I still see the disclosures.
Okay. Okay, great. I'm going to go to the next one for you. Here we go.
And if you can give me the control, I can just start that as well, please.
I'll just go ahead and drive, Vafi. Go ahead.
Okay, I can still see the disclosures.
Okay, why don't we go ahead, maybe Dr. Lee, why don't we go to the next one, and we can help Dr. Salmasi on the back end and come back.
Oh, I see his slides now, actually, I believe.
Yes, I can see them now.
Okay, great. Okay.
Okay,
There you
so
go.
as Dr. Lee mentioned, I am going to talk about the basics of radiofrequency. So talking about anesthesia first, anesthesia has evolved significantly over the past several thousand years, and the biggest one was the local anesthetic, the bottle that you saw, the bupivacaine. You give a bottle of that, a needle, and an ultrasound probe to someone like Dr. Einar Otestad, and basically you can make any part of the body that he wants completely numb, but only for about 10 to 12 hours. Then the effect of the local anesthetic is gone, and can I have the next slide, please? I'm basically looking like this, scratching my head to see what is the best next step. And either I can freeze the nerve or stimulate the nerve. The next slide, please. Or we can fry the nerve. The next slide, please. And actually, we have a technical term for frying the nerve, which is called radiofrequency ablation. It is destruction of dysfunctional tissue using heat generated from alternating current of medium frequency. Some of the parts of this definition can be used a little bit later in this lecture. And we are not the only subspecialty of medicine that is using this. We are sharing that with a lot of other subspecialties. And can I have the next slide, please? So there are many, many different companies at this point that are producing these different machines and generators for radiofrequency ablation. Some of them are even major neuromodulation companies. But why radiofrequency is helpful and important? Why am I using that in my practice? Basically, I can create a smooth, well-circumscribed lesion that I can modify and configure to the best that I can use, but I need to be aware that basically I'm heating up the tissue to create that lesion. So it can cause some unwanted charring, boiling, burning of the tissue. If the nerve that I'm targeting is a large nerve, it is not reliable. And also, can I go back to the previous slide, please? The other problem with this is that if there is a motor component, probably radiofrequency is not the best option. Of course, the nightmare that all of us have, neuritis, which is painful for both the patient and for the physician. And next slide, please. So just we talked about radiofrequency ablation, that is using electrical current to generate heat. What about heat? Heat itself has many different effects. At about 50 degrees Celsius, you see that you start having some lethal changes in the cell membrane. And this is the temperature that is actually present in the tissue, not the temperature that you see on your machine, which is the reading from the tip of the needle. So you might be reading at 80 degrees, but then your tissue temperature might be still at 50 degrees, but still you are achieving what you want from that radiofrequency treatment. Can I have the next slide, please? The other component of radiofrequency ablation is the electrical current. The electrical current, it is alternating current, so it can create either a magnetic field, which at the frequency, medium frequency that we use is not applicable, or electrical field. As you all know, there are a lot of charged particles around the neuron cell membrane. And if you put them in an electrical field, they can have a lot of different changes. They can cause some just stress on the membrane. They can cause some friction and heat generation. And basically, they change the behavior and the structure of that neuronal cell membrane. And all of these things are important to see how we can modify and adjust our lesion to understand how heat and electricity work on our tissue and deliver the energy. So the size of the lesion is affected by two factors: how we deliver the energy and how the tissue receives that energy. Regarding the local physiologic characteristic of the tissue, how the tissue receives the energy, there are not a lot of things that we can modify. Can I have the next slide, please? And the next click. There have been a lot of work by Dr. Provenzano in this field. The only thing that probably we can modify is by different injectates that we use. Most of us use the lidocaine, which is, as you can see in the middle, in the size of the lesion. If you want to really maximize the size of your lesion, you need to go to hypertonic saline. But is it necessary? We will see. And then next slide, please. As you can see in the next slide, there are, no matter what injectate you inject, at some point you're going to reach a plateau of the lesion size. So the one that is more modifiable is the energy delivery. The delivery of energy depends on the shape of the tip of the needle that you're using, how large your tip is, both in the length and the diameter, and also how high you dial in your temperature and how long you're burning the tissue. Out of these five, probably the shape of the tip and the temperature of the tip are the ones that are most modifiable. The other ones you can certainly modify, but to a limited degree. For example, you can go from a 21 gauge to a 17 gauge. You can go from 0.5 to 1 centimeter of the tip length, but probably you cannot put an active tip of 5 centimeter. You cause a lot of other tissue damage. And the same thing with the lesion time. As you saw in the previous slide from Dr. Provenzano, after about 80-90 seconds, you hit a kind of plateau, and you cannot go basically 30 minutes burning. There are a lot of these fancy designs of the tip of the needle to try to optimize the pattern of the electrical field and the pattern of the heat to increase the size of your lesion. As we can see in the next slide, the different type of the lesion, the different type of the needle tip can affect both the heat pattern and electrical pattern. Because of these potentials of creating larger lesions, I personally use them a lot in my practice. But can I have the next slide? There is not a lot of clinical data endorsing that. So I use them, but without a lot of clinical data. You don't need a fancy needle tip to create a larger lesion with a different shape. You can use two regular radiofrequency needles and create a bipolar lesion. The important thing is that you need to make sure that you place your needles appropriately, because if you place them too far apart, as you can see, you go from a bipolar lesion to two unipolar smaller lesions, which is exactly what you don't want. That is why in the next slide, you can see that Dr. Cheng and his group have created a mold for sacroiliac joint denervation. And basically, they put the needles through the holes in that kind of pattern, and they make sure that their needles are appropriately placed. By doing this, as you can see in the next slide, they have shown that their technique is even more superior than cooled radiofrequency. So you can optimize the shape of the tip really far along with different tip designs, or by using 2 needles. But I just mentioned cooled radiofrequency. Why do we even use the word cooled? I mentioned that the mechanism that we are using is heat, but at some point your heat is not what it is helping you. The heat is something that is limiting you at some point. So next time that you're doing a radiofrequency treatment, please do me a favor. Look at the energy output of your machine. You see that at the beginning, when you're starting your treatment, the energy output of your machine is around 40 volts or so. And as you go on through your treatment, as the temperature stabilizes, your energy output drops down. Because what happens is that at that point, the needle tip is where you read the temperature. The machine does not want to make it hotter. And that is why it decreases the energy delivery to maintain that temperature that you have. So the question comes that why not cranking up the temperature to 120 degrees? You can, but then you are going to face a bigger problem, because you are going to burn the tissue right next to the needle, and then that burnt tissue does not conduct heat or electricity. And then you're creating actually a smaller size lesion rather than a larger size lesion. So that is why, by cooling the tip of the needle artificially by some fluid running around the tip of the needle, you can deliver energy more consistently throughout your lesioning time, and you can create a larger lesion size. And that's how cooled radiofrequency works. Can I see the next slide, please? And there is some data, both clinical and anatomical, for use of cooled radiofrequency for denervation of different joints, but I leave that for more fun lectures after this. The pulse radiofrequency is the last topic that I want to touch upon tonight. And the reason that I'm just touching upon that, and I'm not talking a full lecture about it, is that unfortunately a lot of payers are not super excited about this technique. The most important thing to notice and understand is that pulse radiofrequency is not an ablation technique. It is not lesioning, it is not thermal. It is a neuromodulation technique. That is why a lot of parameters that we dial in, as you can see after one click, in these parameters, can you click once more, please? So a lot of these parameters that we dial in when we are trying to do pulse radiofrequency are similar to the ones that you use in peripheral nervous stimulation or spinal cord stimulation. So you dial in the energy delivery. In a spinal cord stimulation, it is amplitude. Here it is the voltage that you're dialing in. You dial in your frequency. You dial in your pulse width or the pulse duration. But in addition to that, this is a limited time procedure. Again, can you please click once more for the slides? And when you are doing this and you are actually limiting the time of the procedure, you need to decide how long you're going to do the pulsing. And the longer the better, but again, there is no hard data how long is the best option. The other thing is that you don't want to heat up the tissue too much, because this is a non-thermal, non-lesioning technique. So instead of dialing a temperature that you want your machine to reach, you actually want a temperature that you want stable and as a limiting temperature. You don't want your the tip temperature to get beyond a certain number, which is usually around 42 degrees Celsius. And as you can see, these are the parameters that I mentioned. Can we go to the next slide, please? So unfortunately, clinical data that is present for pulse radiofrequency is not just tremendous. Most of the data is small clinical trials, some cohort studies, a lot of case series. So that is why the pulse radiofrequency is not accepted that well by our payers. But the data is not that far behind a lot of other just parts of the pain medicine that we are doing. So hopefully in near future, we can just see more of the pulse radiofrequency. So before finishing, I just want to reemphasize one thing about this lecture, and then I'm going to just hand it over to Dr. McCormick. Basically, the most important thing is that this was probably the most boring lecture of tonight. And the reason for that is that it's about the basics, but the basics are very important to understand them, apply them to optimize the lesion size that you're creating for each specific individual that you're treating and each specific nerve that you're targeting. And this is important for both efficacy of your treatment and avoiding complications. Thank you very much, everyone. And I pass it along to Dr. McCormick, which is going to have a much more fun lecture than mine.
Good evening, everyone. Dr. Salmasi, I'll say that was definitely not a boring lecture. I enjoyed it, and I'll go ahead and reinforce some of the foundation that you laid down. So, can I get the next slide, please? Thank you. I'm not sure I saw a disclosure slide, so I'll just mention that the relevant disclosure for me, I do receive research funding from Avanos Medical, who manufactures cooled radiofrequency ablation technology. But I'll of course do my best to bring parity to what I'm going to talk about. So I will speak about facet joint and sacroiliac joint radiofrequency ablation. I'm going to focus on lumbar facets mainly just due to time. I'm also happy to talk about these things later on. I'm going to talk about both selection considerations as well as the radiofrequency ablation techniques themselves. So we'll talk about lumbar facet joint pain first. If we can advance to the next slide, please. Oh, if we can just move back one slide. Thank you. So this is Dr. Schwarzer's study that many are probably familiar with, and this is over 25 years old now, so it's not new information, but this is some of the foundational literature that showed us, it started to build an understanding of the diagnostic medial branch block for the lumbar medial branch nerves in particular in this case. So Schwarzer showed that a single diagnostic medial branch block where a 50% pain relief threshold was used to consider this a positive block is associated with a 38% false positive rate. This has been confirmed by further science through the years. We'll go to the next slide. Thank you. And which is that, along with additional studies, led to the development of these dual block paradigm protocols to select patients for radiofrequency ablation. If we can just go back to that past slide briefly. Thank you. So, SIS guidelines, many are familiar, recommend dual concordant medial branch blocks. The percent relief threshold varies depending on cervical versus lumbar spine, but lumbar recommended to be at least 80% relief. And we can go to the next slide. Those the SAS guidelines have been somewhat controversial. Certainly not all physicians and not all spine, pain, and other specialty groups agree. These are recent guidelines published just months ago by Dr. Cohen and then a group from the NPW, multiple societies all weighed in. There wasn't complete consensus on all the recommendations, and there are many, but I'll focus on just two relevant to what I'm speaking about tonight. So this group did ultimately recommend a pain reduction threshold of 50% to be considered a positive block rather than 80 or perhaps 100%, a much higher bar. The group recognized that patients who are selected by at least 80% relief by a medial branch block are more likely to experience success with radiofrequency ablation. But the group ultimately decided that to essentially not include, well, essentially that lower thresholds, they do have more false positives, but they eliminate false negatives. And so not withholding a treatment that may be helpful from the patient. So disagreement, but this is where this multi-society group did come down. If we go to the next slide, similar here. So this group, again, not with complete consensus amongst societies, but recommended a single branch block as opposed to the dual block paradigm as SIS recommends. Same idea here, same rationale that the goal is in the case of this group to maximize the number of responders, but not necessarily the responder rate. So you're going to ultimately have more treatment failures, but a total number of total number of treatment successes that's larger with a lower block threshold by percentage and also by a single block as opposed to dual blocks. So moving along to technique considerations, this is a classic image from an old paper that is probably familiar to many. And what you're seeing here on the left portion of the figure is a comparison of parallel technique to perpendicular technique with a conventional radiofrequency electrode. And in the right side of the figure, you're seeing essentially caudal tilt. If you imagine that you're looking sort of down the barrel of where the medial branch nerve traverses in that saddle between the SAP and the transverse process, you can see that between the left and the right, just how little of the nerve is actually going to be captured by a typical conventional radiofrequency lesion. So the take-home point here is that if we're using conventional radiofrequency ablation, it's vital to use parallel lead placement in relation to the nerve. The next slide, I see it coming up here. That's great, thank you. This is a CT tomography reconstruction of a spine model with a radiofrequency probe laid in proper location with parallel technique. I don't believe I have control of the cursor in a way that you all can see, but the point here is that with parallel technique in a true AP view like this, if we can just stay on that slide for a moment. Thank you. In an AP view, this is the trajectory of the needle that you should be visualizing. So it should appear that it's coming from lateral to medial, from skin to target, and it should appear that it's coming from caudal to cranial, as that needle is in the left panel. That's going to lay parallel to the medial branch nerve. In the lateral view, you're seeing the electrode advance close to the foramen, the neural foramen, but not clearly just outside of the foramen, such that we're not going to damage the exiting nerve root, but clearly ventral enough that we're going to capture a long segment of that nerve. Let's go to the next slide there. Thank you. Great. So that's conventional radiofrequency ablation. Of course, there are a number of other technologies, and Dr. Salmasi touched on these. So most of the other novel technologies, they allow for perpendicular placement, the exact opposite of what we want with conventional radiofrequency ablation if we're doing our best to capture the largest segment of the nerve. So this is showing in the left-hand panel, those dotted lines represent where the medial branch nerve lives. In the right-hand panel, you're seeing two cooled radiofrequency ablation probes, electrodes that are placed, and this would be perfectly appropriate. So whereas if we were using conventional probes, this would really only capture perhaps a very short segment of the medial branch nerve. With cooled, the spherical geometry and the forward projection, this is an acceptable looking lead placement. The same would be true of dual-tined or three-tined trident type novel radiofrequency ablation technologies, whereas again, not the case for conventional electrodes. So let's go to the next slide. Great. So now if we take a look at the literature, so what can we learn from the primary data? Well, these are sort of old, well-known landmark studies, the Dreyfus study and the McVicker studies. Both of these were prospective trials that use dual medial branch blocks to select patients. 80% relief in the Dreyfus study, 100% in the McVicker study. Both use large gauge conventional radiofrequency electrodes, 16 gauge, excuse me, with parallel technique. And you can see the results. They're quite impressive. So this is kind of the gold standard. And we know that if we use a dual branch block selection technique, we use parallel technique and large gauge electrodes, large lesions, we should see excellent outcomes. Let's go to the next slide. This is some of our own practice audit data that we recently published in Pain Medicine. So these were patients that we selected by dual medial branch blocks. We used cooled RF technology in this case, not conventional technology. This is with a 4mm active tip. And you can see in table 2B, what's shown is that we saw approximately a 57% responder rate if we were considering success to be at least 50% reduction in pain, and this is at 6 months. So not quite as impressive as what we're seeing with the Dreyfus and McVicker data, but remember that we didn't use quite the same selection protocol as McVicker. This is real world data. So this included patients with spinal fusions and adjacent segment degeneration, scoliosis, spondylolisthesis, high BMI, patients that would have been excluded from those two tightly controlled prospective studies that I showed. So again, we're seeing that if we select with dual branch blocks and use a large lesion, that we see fairly decent outcomes. Let's go to the next slide. This is just showing the durability of treatment. So you're seeing on the left-hand side, the responders are shown above the horizontal dash line. Those are each bar represents a unique patient, and those are all patients that report at least 50% pain reduction at 6 months. In that middle pane, you're seeing the same patients, but now followed 12 to 24 months post-ablation. And then finally in the panel on the right-hand side, that's patients reporting on outcomes after 2 years follow-up after their RF. So we're seeing, we see treatment durability there. This next slide is showing a bit of a step down in selection. So selection and technique. So this is an old RCT that we did. This is from Northwestern. We only use a single branch block. So these were tightly selected patients in that we excluded high BMI, there were no fusions, there was no scoliosis, generally a population that's more likely to respond to radiofrequency neurotomy, but they were only selected by single medial branch blocks. And then in one group, they received cooled RF with a 4mm active tip. The other was a 20 gauge electrode, single lesion. And you can see, and again, in the tornado plot on the right side, about a 50% responder rate with cooled, a little bit less than a 50% responder rate with traditional RFA, conventional RFA. And I would chalk that up to the smaller gauge electrode, single lesion and single branch block, why we're not seeing as robust of outcomes as McVicker and Dreyfus reported there. Let's go to the next slide. And then finally, this is data from the MINT trial, and the take home here is single branch block, 50% relief threshold, non-parallel technique, so perpendicular technique with a small gauge electrode, your responder rate falls down to 34%. And let's go to the next slide. Great, so we'll move along to the SI joint and dorsal ligament complex. So very common question, what do we use, intra-articular injections or do we use sacrolateral branch blocks to select for neurotomy? Major technical, inherent technical issues with intra-articular injections used for diagnosis. So we know that a certain proportion of patients will have rents or defects in the anterior joint capsule of the SI joint. We know that there's, in some patients, communication of the SI joint with the S1 foramen, where you're going to have leakage of anesthetic to nerve roots. Clearly, that's going to cause false positive results. And then it's not necessarily the case that you can access the joint in every single patient. So probably about 50% of the time, when we think we're in the joint, we're not really there. And that's been confirmed by cadaveric studies. So the other issue is when we think about intra-articular versus sacrolateral branches, well, The neurotomy is treating the sacrolateral branches. That's what we're denervating. We're not touching the interarticular portion of the joint. So it really makes a lot less sense to select patients by an interarticular block procedure as opposed to blocking the nerves that we're actually going to then go and ablate. So let's go to the next slide. So this is Dreyfus's data. This is Dreyfus's study on really the only validated technique to date, at least until further science is performed, that multi-site, multi-depth sacrolateral branch blocks are a valid way to anesthetize the lateral branch nerves. And let's go to the next slide. Just in the interest of time, I'm not going to go through all the details of the study, but and if you can click the next, it should bring up some arrows. Yeah. So essentially, when Dreyfus and his group compared sham injection to active local anesthetic, the active local anesthetic was able to effectively anesthetize the dorsal ligament structures and the posterior joint capsule, but not block pain associated with capsular distension. And from this study, we actually know nothing about what happens to nociception in the articular surface itself. So take home here is this is a good way to select patients for presumed, or I should say to diagnose presumed dorsal ligament or posterior capsule pain. And knowing that if these patients respond to that type of block, they should respond to radiofrequency neurotomy of those sacrolateral branch nerves. This is showing outcome data. The two best, tightly controlled, randomized controlled trials, Patel and Cohen, both had essentially a 50% responder rate. And that probably has to do with selection criteria. It may have to do with technique as well. If we go to the next slide, we can learn from some of the retrospective data. So some of these studies use dual block paradigms, others use only single block paradigms. And generally, if you just look at the trend of responder rates over in the far right-hand column, you can see that the studies generally that use a dual block paradigm had a greater or higher responder rate than those that didn't. Let's go to the next slide. So part of this, of course, again, selection, very important. Technique is the other issue, and we likely haven't optimized our techniques for sacrolateral branch denervation. This is from Roberts and Stout's study that's also fairly recent. This group dissected cadavers, laid down radiopaque wires at the lateral branch nerves, and then imaged them under fluoroscopy with the epsilon ruler that you see there for scale. And they used ImageJ software to overlay those purple circles, which are modeling where a radiofrequency lesion would cover, essentially. So this is not a clinical study. This is purely cadaveric dissection with imaging overlay. But you're seeing the various techniques that have been reported in the literature. So various conventional monopolar techniques, small gauge electrodes, very small lesions, clearly qualitatively not really covering those wires which follow the lateral branch nerves. When we look at those cooled monopolar lesions, they're larger. They clearly capture more of those represented nerves by the wires. If we advance to the next slide, we'll see some of the bipolar techniques. These bipolar techniques, again, qualitatively do seem to cover more of those nerves, whether it's the periforaminal bipolar techniques or the strip lesioning techniques, so the Palisade with conventional electrodes, or some of these lateral crest or other techniques using dual-tined electrodes, which are what are shown in the bottom four panels. And then if we advance to the next slide, what we'll see is the quantification of what's going on. So this histogram shows the percent of sacroiliac joint specimens in which there was 100% lateral branch nerve capture, according to the modeling by Dr. Roberts and Stout. And what you see there in the conventional monopolar techniques, very low rate of capture. One of the cooled monopolar techniques, V2, had a 92% rate of capture. But then if we look at the red bar and the purple on the far right, those are two strip lesioning techniques, and they had the very highest rate of capture, bipolar strip lesioning techniques. If we go to the next slide, I just highlighted those three techniques. These are the three that performed best. So nearly 98% rate of 100% branch block capture. So let's go to the next slide. This is just the summary. So again, the greater our thresholds for selecting patients, the higher our responder rates will be. But of course, that will we'll leave out some patients who are false negatives who may have responded to RF. But certainly, there's no disagreement that we need to do our best to capture the nerve as far as the technique goes. That's going to be performed with a parallel technique with conventional electrodes, large gauge electrodes, or multiple lesions. And then, of course, as I mentioned, the angle of approach is not as vital with some of the newer technologies. Then for the sacrolateral branches, again, the only validated technique is the multi-site, multi-depth blocks. And it appears, at least from Dr. Robertson Stout's data, that bipolar strip lesioning techniques likely perform the best. So that's what I have, and thank you very much. I believe Dr. Pritzloff is going to speak next about peripheral joint denervation.
Great, thanks, Zach. That is a hard act to follow there, lots of science. So I will do my best. My goal here, next slide, is really to, and here's just my disclosures here, some of the work I do for some of the peripheral stim companies. Next slide, keep going. My goal here is to really present a practical approach to some of the things that I've been doing with large joint denervation, and certainly some of the science and really amazing work that's done from an anatomy perspective, looking at a lot of these articular branches for both the hip, knee, and shoulder, really just in the past couple years. Next slide. This is just really to show you that first patient of someone who has severe osteoarthritis of the hip joint and really isn't a good candidate for a total hip arthroplasty and is considered to be high risk. And so with any of these patients, whether it be hip, knee, or shoulder, the question is, what are the indications? And I think, you know, if you're going to start doing large joint denervation, you may limit or shrink down what your indication comfort is. But certainly some of the indications include things like RA, OA. A big one that I think a lot of us see, post arthroplasty pain. For cancer pain, if someone has erosive metastases, that can be an indication. Osteonecrosis, and then certainly one that you know, can sometimes be met with discomfort, meaning if someone has chronic infection, and I've seen a few of these patients recently, and they're really no longer candidates for repeat hardware exchange, might they be a candidate for denervation? Next slide, please. So we'll start momentarily just talking about the knee, but the question is, with any of these procedures, what are, one, some of the things that I've seen and experienced, and two, what are the theoretic risks? I always tell patients that, you know, they should expect that they may have pain for an upwards of a week after a denervation, because, and this really depends on the system that you're using, whether it's a larger lesion size with cooled RFA, or you're using some permutation of a bipolar or tripolar lesioning technique, there is collateral damage. And so I let patients know that pain is always possible. Hematoma is also possible, and I will show you a sample algorithm from my institution that I helped to develop. But you really need to make up your mind and, you know, what your threshold is for anticoagulation. Certainly, these are not considered to be high-risk procedures, and in a lot of ways fall into a medium risk category. And there's a lot of shared risk decision-making about whether you will continue anticoagulation or not. And then finally, nerve injury, always a possibility. And I think a lot of this is really mitigated both by knowledge of anatomy ahead of time, and then secondarily, if you can maximize success with other modalities, including things like ultrasound, which I employ quite a bit to avoid neurovascular structures, that all can be helpful. Next slide. So the issue is ablation is not always easy. These patients are seeing you for a reason, oftentimes because they either are not good candidates for a joint replacement, or secondarily, they don't want a replacement, or they're considered high risk, a multitude of reasons. And so oftentimes you're dealing with situations that are not optimal. I will comment on the hip, because that certainly, of all of the ablation techniques that I will discuss, involves deeper placement of needles. And so BMI consideration, positioning are all factors. These are also factors for the knee, for example, as well, but are worth noting ahead of time, and sometimes requires good planning on the part of the practitioner on how you're going to proceed with the patient. Next slide. So we'll get into the knee. Next slide. I think, what's interesting about the knee, this is just showing the vasculature on the first side of the screen of the knee. And often a simplistic picture was painted, meaning singular genicular nerves traveling with a single blood vessel, which led to a landmark technique done with fluoroscopy targeting supra and inframedial genicular branches, as well as a supralateral branch. And for the longest time, targeting for the knee, this junction at the metaphysis or epiphyseal diaphyseal junction, where the shaft meets the condyle, is typically what has been done, aiming for the mid part of the shaft. Next slide. With some of the work that Philip Tran, Philip Peng, and John Tran have done with Ann Auger out of Toronto, we've learned and really they've delved in to the anatomy of these nerves, and really have shed a multitude of light on that there's a robust innervation to the anterior knee that involves things like the nerve to the vastus lateralis, nerve to the vastus medialis, your superior genicular nerve, superior lateral genicular nerve, your common fibular nerve, recurrent fibular nerve, and it's really a network. And so I think that's important to really take note, because a singular burn with a small cannula may not yield good results, and it's really incumbent to understand this anatomy and how these nerves really converge to innervate the anterior knee. Next slide. So one of the things that I've employed is ultrasound, and I've done this really to improve accuracy, as well as to really get a sense of where the vasculature is, and then finding, for example, the inframedial genicular nerve seen here in box A, a group of bubbles that are traveling with that nerve with that artery to maximize your success, first in a long axis view and then a short axis view. And this, I've found, really, one, can improve accuracy, and two, oftentimes I find where I'm placing my needles in some ways are not at the traditional anatomically taught positions for the knee. And so once again, it's something that I think takes time, and if you have interests, I think this can also in some ways improve comfort for the patient, meaning you're not really skiving and scraping along periosteum the entire way, and can be a little bit more elegant in your needle placement. Next slide. There was a great paper that came out recently by a group in Belgium. This is in regional anesthesia and pain medicine, and really showed with a cadaveric selection. So they did some injections with dye and looking at supralateral, medial and inframedial genicular nerves, and really looking when you injected, where are you in fact covering these nerves. And what they surmised and came up with is, in fact, for the knee, some of our more traditional approaches may not always get some of these nerves. And in fact, for some of the supralateral and infralateral, supralateral and supramedial branches, that in fact a more distal or inferior and posterior approach to the posterior cortex can actually yield better results. Now, keeping in mind This is all going to be dependent on which system you are using. And certainly if you are using something, perhaps say with a cooled RFA system, you may be getting these anyway, but it's something to think about if you're getting failures in a patient, or a patient does not have a good outcome with the RFA and oftentimes has a positive result with the block. You have to think and say, hey, look, did I in fact miss the nerves with the ablation? Other are just considering anticoagulation. We routinely at our institution do not stop anticoagulation for our knees, either for the genicular block or for the RFA, but you may consider, and it just really depends on the patient's bleeding risk and your ability to do this in a expeditious and effective way. And then I already talked about imaging. Positioning is also a consideration, and sometimes the patient is unable to extend the knee, and you have to get creative on how you're going to approach the knee, especially if you're using your fluoroscope to get an optimal image, especially for laterals. Next slide. So moving on to the hip, once again, real patient that, keep going, next slide, real patient that I had, and post-arthroplasty pain, there was no shortage of this, and this patient you know, had a prior total hip arthroplasty, had a fall, no hardware loosening, but was having a lot of nociceptive hip pain. And so the question was, how could we adequately treat this and go after this, since there were no other surgical options? Next slide. The innervation of the hip has been well described for over 70 years, and even dating back to Gardner in the late 40s. Really was ahead of the time, you know, describing the anterior innervation of the hip being supplied by the articular branches of the optic nerve, or the accessory obturator nerve, and with the remainder of the branches being covered by the femoral nerve. Posteriorly, you're getting a sciatic innervation and innervation coming from the superior gluteal and quadratus nerve to the quadratus femoris. And most people are not doing any sort of intervention posteriorly, and the bulk of what we're doing is targeting the obturator articular branches, and if there's certainly accessory obturator, which I'll talk about in a minute, and the femoral articular branches. Next slide. It's important to note accessory obturator nerve. So depending on the literature that you, approximately 30 and upwards even of 50% of people will have an accessory obturator nerve, which pretty small, and it arises from the third and fourth lumbar nerves and descends along the medial border of the psoas and crosses the superior ramus of the pubis and kind of passes underneath the pectineus, where it divides into branches. The obturator articular branches come off the obturator nerve as it descends through the obturator foramen, and so these are, you know, predominantly providing innervation to the medial aspect of the hip joint. Next slide. And Peng and company have really just done amazing work with regard to cadaveric dissection. The green here is showing the accessory obturator nerve in this cadaver. The orange along the bottom is obturator articular branches, as well as the femoral articular branches, which are shown in a purple color. And so we're really trying to target and really hone in on all of these branches that are giving sensation to the anterior hip. Next slide, please. And so the question is, how do we do this? You know, this is you know, this is kind of an example of some of the approaches, but that, you know, the femoral articular branches along the superolateral aspect of the acetabulum easily kind of picked off there, keeping in mind that once again, you know, you have something called your inferior iliac spine that sometimes can get in the way. And so once again, I sometimes do this in tandem with ultrasound to really help with that superior needle that I place. The middle picture is showing an approach to go after and ablate articular branches, keeping in mind that this is really the confluence. It's really, we call it the teardrop or the incisura, where the ischium and pubis are really coming and joining together. And you just really don't want to meander too close to the obturator foramen, with risk of causing nerve injury. But that needle, this needle, is particularly deep, and in a lot of patients can be uncomfortable, and you're typically using a longer 15 centimeter longer cannula to reach this area. And many people do it many different ways, meaning some people approach from an inframedial trajectory, some people approach from an infralateral. What is very important with that needle placement is that the femoral artery and neurovascular bundle typically overlie that needle placement. And so once again, if you have some access to an ultrasound machine, I'm typically using that ultrasound to watch my needle slip by the neurovascular bundle, and then I'm able to maneuver it into place. Next slide. So the question is, what have we been doing and what has our approach been? And this is a sample algorithm. I'm not claiming that this is right or wrong because the algorithms are going to vary. But a few of the selection criteria we've established are BMI cutoffs, which may seem overrestrictive, but the reality is the larger the patient is, this, and I've had cases of this can be incredibly difficult. We have also, probably to a restrictive degree, and because some of our providers and physicians only do fluoro, stop anticoagulation for the ablation. And if a patient can't do that, once again, it would be a shared risk discussion. So these are just some of the things that we've really discovered and have done with kind of better comfort for the patient, better success for the patient doing the procedure. One more thing to point out is we do also set our threshold kind of high for a goal pain relief of 80%. And Dr. Badia's papers and review, you'll find that, it's really all over the place depending on the study you look at, how people are doing this, meaning the amount of local anesthetic for the block and the approaches, and certainly, I mean, even with that meta that he did, relief range from anywhere from 8 days to 3 years. So it's really hard. I think we're coming along with the science, but we're still establishing what's the best practice. Next slide. Getting into the shoulder, and next slide after that, this is a patient, once again, who has bone-on-bone osteoarthritis, luxation, just go back one slide real quick, and was not a replacement candidate. Next slide. A lot of the literature recently is focused on purely looking at ablation techniques or pulse radiofrequency. And as Dr. Salmasi said, pulse radiofrequency is not it's not an ablative technique. You're not destroying the nerve. But a lot of them have looked at just ablating the suprascapular nerve, and that's been purported to be responsible in upwards of 70% of innervation to the shoulder, to the capsule. But there are two other nerves that we'll talk about. Next slide. And this is what I would consider to be, of all the joints, the one that's evolving the quickest and really is the newest. Dr. Tran's paper that was in 2019, really looking at not ablating the suprascapular nerve at the suprascapular notch, as really shown on the left side of the screen, but really ablating it at its distal branches, where you're only going to be targeting the sensories that are going to the glenohumeral joint. And so they had a very interesting spacing need, both at the notch and halfway between the suprascapular notch and the spinal glenoid notch, and really found that the farther toward the spinal glenoid notch you are, the higher the likelihood that you're only going to get the articular branches of the humeral joint. Next slide. Max Ekman, who's at Texas Tech, also put out a great cadaveric review showing kind of the zones. So the question is, what are the two other nerves? The two other nerves that are supplying sensation, one posteriorly is the axillary nerve, which emerges through regular space and starts giving, as it courses superiorly, gives sensory branches to the superior and lateral aspect of the glenohumeral joint posteriorly, and then the lateral pectoral nerve, which emerges and it provides sensation proximally to the pec major, but as you start coursing laterally toward and past the coracoid, really getting into an acromial branch and branches that really supply sensation to the anterior and superior aspects of the glenohumeral joint. Next slide. And so these are the needle placements. And once again, depending on the system that you're using, showing, you know, firstly, from a posterior approach, getting that suprascapular nerve at its kind of far superolateral extent where the articular branches run. The second picture showing the axillary nerve, distal or articular branches at the greater tubercle of the humerus. Next slide. And then we're almost done here, just showing the lateral pectoral nerve. So this is tricky. And once again, you have to be careful here because, you know, you have the thoracoacromial artery that's traveling this area. You have the brachial plexus that's traveling inferior to the coracoid. And so really the goal is to be targeting those articular branches as they course laterally, just along the inferior aspect of the coracoid, but not inserting that needle too far, too deep or too far inferior to that point, because you're at risk of causing both vascular as well as potentially damage to the brachial plexus. And this is, once again, a consideration depending on the system that you're using. Ultrasound can be an effective way of mitigating those risks. And so with that, I'm going to turn this over to Dr. Smuck, and we'll, you know, obviously address some of those summary points in the review here.
All right, thank you, Scott, and thanks to everybody who stuck around to the end. I am going to talk about vertebrogenic pain. These are my disclosures. The relevant disclosures highlighted at the bottom, and that is that it was the Stanford PI on a study funded by Relievant. It was a randomized trial of the Intercept treatment, which is the only product on the market currently for basovertebral nerve ablation. And that product is FDA approved for the purpose that we're going to discuss here. I want to compare and contrast vertebrogenic pain to discogenic pain. And I think all of us are very familiar with discogenic pain. It's one of the most common types of chronic back pain that we tend to see in clinic. But vertebrogenic pain is emerging as a subcategory of that type of pain presentation, where a patient tends to experience more pain in flexion postures, prolonged sitting, and has a vertebrogenic component to that pain that turns out may not just be a discogenic pain, or in fact may not be discogenic pain at all, but purely vertebrogenic pain. So, you know, hopefully you're asking at this point, well, you know, what are you talking about? Can the vertebrae cause that type of back pain? And try to convince me of so. Next. Interestingly enough, early in the days of the development of diagnostic criteria for discogenic pain, it first had to be proven that the discs could cause pain. And that was done through good anatomic research showing nociceptors and annular fibers, the development of the Kirkcaldy-Willis discogenic or degenerative cascade, showing invasion of nervous tissue into defects in the annulus and other processes that went along with the potential for pain generation. And the same work has gone into looking at the vertebral end plates. In fact, it turns out that the innervation density of the vertebral end plates is greater than the innervation density of a disc. Next. Also, like the disc, when the end plate is damaged, the number of nociceptors in that area increase. Next, please. And the concentration of nociceptors within the end plate increases to a greater degree at the end plate than it does in the damaged portions of a disc. So from a neuroanatomic standpoint, the possibility of pain from the vertebral end plates is quite high. So then the next question is, how do we determine if somebody has vertebrogenic pain? So anatomically it's possible. What's the way we diagnose this? Next. The way it's currently done really is through MR, and MR specifically looking for modic type 1 or modic type 2 changes. And that is because basic science research into the genesis of modic changes has shown that the types of injuries that lead to this increased innervation of the end plates occur alongside modic changes. And there's abundant basic science research on this. In fact, more basic science research on this, I would say, than discogenic pain, if you put it together. Next, please. These changes do result in not just the innervation, but hypersensitivity. All of this is supported by really good work from Dr. Dudley and his lab, which received the Issels Prize for the research into this type of back pain. Next, please. Now, you're also probably aware that the literature shows a pretty good correlation between modic changes and back pain. While most MRI findings are not very specific for back pain, modic changes are one of those findings that are seen in much greater frequency in people with back pain. And in fact, people with type 1 and type 2 modic changes are also known to have a very high likelihood of positive discography, even up to 100% if the modic changes are extensive. So it could be that the disc pressurization is not pressurizing the annulus and causing the pain in some instances, but actually deflecting the end plate and creating mechanical pressure and pain from the end plate. And in fact, the end plates do move during the pressurization of discography. Not only that, but modic changes are associated with severity and duration of back pain, meaning that patients with modic type 1 and type 2 changes on MRIs are more likely to have higher severity of pain and more likely to have a longer duration of pain. They seek care more often than people without them, and they're more resistant to conservative treatments. And then work on the surgical side has showed that patients who have modic changes are more likely to have continuous back pain, even with resolution of radicular pain after a microdiscectomy. Next, please. So let's hone in a little bit on the anatomy of vertebrogenic pain, and specifically the innervation of the end plates, and that is through the basovertebral nerve. And in this area, like most other anatomic locations, the nerves are located with the blood vessels. Now, the arterial supply to the vertebral body is quite random, but the venous vasculature is very standard and flows from the vertebral body into the vertebral vein. Next, please. And next, bring up the next one, please. The basovertebral nerve co-locates with the basovertebral vein in the basovertebral foramen and exits from the foramen to communicate to the sinovertebral nerve. So the basovertebral nerve is a branch of the sinovertebral nerve, but located within this basovertebral foramen becomes a potential target for a therapeutic denervation of the vertebral end plates. Next. And that is located here. You're certainly aware of the appearance of the basovertebral foramen on a lumbar spine MRI. It's characterized by high T1 and T2 signal intensity in the posterior mid portion of the vertebral body, as shown by the red arrow here. Next. This is a technique that was developed in order to place a probe into the path of the basovertebral nerve at the basovertebral foramen. An 8-gauge trocar is used to transgress the pedicle in a similar fashion to kyphoplasty or vertebroplasty, through which nitinol tamp is advanced, and the curved tamp allows for it to be guided and directed into the proper location in order to create a thermal lesion of the basovertebral nerve. Next. This MR shows pre and post MR findings before and after successful basovertebral nerve ablation in a research candidate. And you can see on the right-hand side the increased T2 signal within the bone of the lesion locations corresponding with the location of the basovertebral nerve on the left side MR. Next. Now, I'm going to review the research on the therapeutic response to basovertebral nerve ablation. The research in the basic science arena is much more abundant than this, and seldom do I get to give a talk where I can cover all of the published clinical research. But today's one of those days because this is all of the published research on clinical outcomes from basovertebral nerve ablation. These studies are all recently published, as you can see, and every single one of these studies is industry sponsored by Relievant, who makes the Intracept product. The first two studies, which we'll go over briefly, are both cohort studies, and then the next two studies are the two randomized controlled trials. There's two publications from the first randomized controlled trial, or the sham controlled trial, which we'll discuss as well. Next slide. Because all of these studies were industry funded and tightly controlled, as a result, they all use the same inclusion criteria. And you can look at this slide and ask the question, who's a candidate for this procedure? This slide explains who that patient is. And that's because these same inclusion and exclusion criteria were used for all of the published clinical studies. And so these are people with chronic low back pain, despite at least 6 months of conservative treatment. They have to have pain of at least 4 and ODI of greater than 30. They also had to have modic type 1 or type 2 changes of no more than 4 vertebral bodies from L3 to S1. In all of the published research so far, I don't know of a single patient with more than 3 vertebral bodies treated. However, the criteria allow for up to 4, and the FDA indications include treatment from L3 to S1. Exclusions include radicular pain, symptoms from spinal stenosis, osteoporosis, or prior lumbar surgery, or litigation and patients on extended release opioids. And then if the MRI showed spondylolisthesis of greater than 2 millimeters or a herniation of greater than 5, then they were excluded from treatment. And primary outcome in all of the published studies was ODI change from baseline to 3 months. Next. So the first study, a small cohort in a 17, next slide, demonstrated the potential for a therapeutic benefit here. And I just want you to pay attention to the ODI change of around 25 points, because that's going to be a recurrent theme in the subsequent studies. Next slide, please. The second cohort study was about twice as large, but conducted by Dr. Trumies and his group down in Texas. Next slide. The outcomes here were a little bit better with a mean 30-point change in ODI from baseline, and tighter confidence intervals likely related to the size of the study relative to the first. And you can see that change at 3 months was statistically significant, as you'd expect with those confidence intervals and that degree of change. Next slide, please. These are the responder rates published by the Trumies study with VAS of 2 on the right, a 75% responder rate, and an ODI change of at least 20 points, also 75% of patients achieved that threshold in this prospective cohort. Next slide. Now we're on to the randomized trials, and the first randomized trial, of course, was the sham-controlled trial. This was a study conducted obviously for the FDA, but also to demonstrate if this procedure that showed some promise in cohort studies demonstrates efficacy relative to a sham procedure. Next slide. This is a consort flow diagram. There's 2-to-1 randomization, so twice as many patients randomized to the treatment arm as to the sham arm. And you can see if you look through this, there's very good follow-up, and in fact, even in the per protocol analysis, around 90% of patients in the treatment arm remained in the per protocol analysis, and almost all of the patients in the sham arm remained through the primary outcome time point in the per protocol. Next slide. And here's the take-home message from a sham-controlled trial. Does the primary outcome achieve statistical significance above sham at the primary endpoint? And at 3 months, the ODI difference was statistically significant between control and sham. You see the treatment group had about a 20-point change, whereas the sham group had a 15-point change in ODI. If you want to put that into comparison, that's about the ODI response of IDET for treatment of discogenic pain in the IDET randomized controlled trials. But the difference was statistically significant, so this does achieve proof of efficacy. But the difference between groups, you know, while statistically significant, is not so great, and that affected some of the research that came down the line, because these results were used to power the next study, which was the randomized trial for comparative effectiveness. Next slide. So this is the comparative effectiveness trial. This is the first report of the second RCT conducted with basovertebral nerve ablation, and this is a comparison of basovertebral nerve ablation to standard care. Next slide. This is the consort flow diagram of the study. This is a 1-to-1 randomization, but otherwise conducted with this very similar protocol as the sham control trial. The difference being the control in this study is usual care, and usual care could include anything but surgery, including other injection treatments. Next slide. Now, this study had an independent data management committee, like most studies like this, that was reviewing the data, and there was a pre-planned interim analysis at the time that 60% of the enrolled subjects completed their 3-month primary endpoint. And the only publication from this study so far derives from that pre-planned interim analysis of the 60% of patients meeting the primary endpoint. And the reason that that was published is because at that pre-planned interim analysis, the results of basovertebral nerve ablation were so robust compared to the sham treatment group, with statistical significance of 0.001 for the primary outcome and all secondary outcomes. And the Data Management Committee said that this result is too good. You've already proven superiority, and you have to stop enrolling patients in the study and allow immediate crossover to all of the patients that are currently in the sham treatment arm. And so those results were published because they were available at that time. The full study of everybody who was enrolled at that time point that finished their follow-up is forthcoming in the near future. So I'm going to talk about the results of this interim analysis. Here you can see the difference in ODI at 3 months between the RF ablation group with a 25-point mean change versus a 4.4 mean change in the standard care arm. You might be asking, how does that 4.4 standard care arm change compare to other studies that have used standard care? Because that's a common comparator for comparative effectiveness studies of spine treatments. And it's very similar. That's really right in the same ballpark as the majority of studies looking at a treatment compared to standard care. Next slide. These are the responder rates. Click once more, please. The top line we'll just ignore now because those are the lower thresholds for ODI and pain. The bottom slide shows responder rates from RF ablation of the basovertebral nerve versus standard care in the darker blue. For an ODI of 20 points, you had almost 63% success rate in the basovertebral nerve ablation versus almost 14% in the standard care arm, and similar but somewhat higher rates of success with a 2-point change in VAS threshold. Now, mind you, these are patients with a very persistent type of back pain that's very challenging for us to treat. Next slide. This slide compares responder rates in the 2 different randomized controlled trials. The lighter bars represent the Intercept study, which is the study I just reviewed with a standard care comparison. The darker bar is the SMART study with the sham comparison. This is only looking at the treatment arm subjects, and you can see that the success of treatment was slightly greater in the second randomized controlled trial than it was in the first. And there's probably a couple of reasons for that. One being that the success of the RF ablation was greater in the second study versus the first, because there were more failures to capture the nerve location in the first study than in the second study due to optimization of the technique over the time between the two studies. Another possible reason for this is that the baseline ODI scores were a little higher in the second study, providing more opportunity for achievement of success thresholds. And then the third is that it was an open label study and patients like being randomized to the treatment arm and don't like being randomized to a standard care arm. And that likely influenced the results to some degree. Next slide. Also recently published were the 2-year outcomes from the original randomized controlled trial, the treatment arm of that randomized controlled trial. Next slide. And you can see that the therapeutic benefit is not only durable, but appears to improve a little bit over time. I can tell you that the 5-year results from this cohort were just accepted for publication, but I'm not allowed to reveal the results yet, but they should be e-published within the next month and look to be very good as well. Next slide. So in conclusion, basovertebral nerve ablation appears to be a promising therapy for a sub-cohort of patients with chronic low back pain. This is a very well-defined cohort of patients who do not have other sources of back pain and have modic type 1 or 2 changes in the lumbar spine from L3 to S1. Consistent outcomes have been observed, as you've seen, in multiple clinical settings, and the results are highly statistically significant in multiple studies. And if you compare the outcome from this procedure to fusion surgery, for instance, and fusion surgery has also, for fusion surgery for chronic low back pain has been compared to standard care. If you compare the results of basovertebral nerve ablation in this population to the results of fusion for chronic low back pain in a much more heterogeneous population, the results of basovertebral nerve ablation are 4 times the effect size of fusion compared to standard care. And long-term follow-up appears to be good, and it likely relates to the fact that the basovertebral nerve is very thinly myelinated, if myelinated at all, and probably does not reestablish innervation once lesioned in this manner. Next slide, thank you very much. And that rounds out the talks. I think now everybody should come back on for a panel discussion.
Thank you very much. And it was very impressive, the amount of lectures. And real quick, we have a little bit of time left. We did get a whole bunch of questions, which is great. It means everybody's engaged and interested. And we'll kind of go in the order which we did our presentations. I'll answer these questions in about a minute or two. For Dr. Vafi Salmasi, we had 2 questions. One was, can you talk a little bit about what that lateral branch template was that you displayed in your slide in terms of how that pertains to the SI joint? And then also your definitions of radiofrequency ablation versus radiofrequency neuromodulation.
So certainly, first of all, I answered the easier one. That study was done by Dr. Cheng, and as mentioned, there is by Dr. McCormick also, there is no kind of specific pattern for where the lateral branches are. So they are really unpredictable. So basically, you want to burn a complete line between the sacral foramen to the sacroiliac joint to try to cover those lateral branches as much as possible. So that specifically module was built for that study. To be honest, I don't know if it is commercially available, but as long as you can reproduce that in placing your needles appropriately spaced, you can certainly reproduce the results of that study. The second question is that the radiofrequency ablation, of course, it's a thermal lesion technique. You ablate the tissue and you create a lesion. And by creating the lesion, you're denervating the nerve that you're targeting or the area that you want to relieve the pain for. For neuromodulation and pulse radiofrequency, it is exactly similar to what you do with your peripheral nerve stimulator or a spinal cord stimulator, but over a shorter period of time with a different pattern and type of the energy delivery. This frequency, as I showed, is usually lower, anywhere between 2 to 8 hertz. and the amount of energy output per charge is a little bit higher as well. So those are the differences usually between the neuromodulation with a nervous stimulator versus the pulse radio frequency. But certainly it is a neuromodulation technique.
Great, thank you very much. Dr. McCormick, a couple questions for you. How often do you repeat your RFAs based off of the data you've seen for the duration of how long your therapies you expect to last? And secondly, when do you decide making a decision between using a cooled RF lesion versus a conventional for a lot of your axial spine?
So the first question, as far as how often to repeat, I mean that certainly just depends on the patient's symptoms. So hopefully we're going to get durable relief. Obviously insurers pay every 6 months, but hopefully we're not needing to actually repeat them every 6 months. I think some of actually Dr. Smuck's data from previous studies showed that the average duration of a repeat was somewhere around 11 months. You have to correct me on that one. The best studies, there are many patients have up to 2 years of results, rather of relief or longer results than that. So again, hopefully it's not every 6 months, but theoretically that's what you can do if you're allowed to do by insurers anyway. Can you, Eric, mention the second question one more time?
Sure. The second question was, you have experience with both cooled versus conventional. Do you have an algorithm or a decision-making tree of why you choose one or the other when you're doing your axial spine procedures?
Yeah, no, fair question. So, realistically, everywhere that I practiced, there was cooled RFA was available, and I practice in a large medical center. These are hospital-based outpatient procedures. So I'm, I guess, privileged that I don't have to worry about the cost of cooled. That's definitely a consideration. I mean, the cooled kit is substantially more expensive than a lot of the other novel technologies with dual tined or 3-tined electrodes, and certainly more than conventional electrodes. So I essentially do use cooled for almost everything. I don't use it for patients with stimulators or pacemakers. I use bipolar lesioning with conventional electrodes to keep the energy simply between the two electrodes where the energy is leaping across, as opposed to energy entering from the electrode itself and then leaving through the grounding pad, where you have the potential to possibly affect pacemakers or to potentially heat up a stimulator battery or that sort of thing.
Great, thank you so much. Next couple questions for Dr. Pritzloff. Scott, two questions that came up. One was in terms of, I know you're at an academic center, but in terms of, generally when the reimbursement and the coding for major joints, are you familiar in terms of if they're doing this as peripheral neurolysis, or is there specific codes for each individual joint? Or do you kind of have that luxury of being an academic institution where it's not very limited or challenging to get those procedures approved?
No, so I mean, you should be aware of the code. I mean, the CPT code, I mean, I'm not going to get in but it's a bundle code, right? For all three. When you start doing things like the shoulder or the hip, you're reimbursed for your first burn or your first ablation, and then usually 50% for each additional. Zach really, Dr. McCormick really, and he's very modest because he's published, on cooled RFA of the knee a couple years back, and a lot, I would say that the modality you're using, the reimbursement, meaning you really have to do the financial analysis if you're going to use some of these kits that can be extremely expensive. And if you look at the reimbursement, I have the Medicare reimbursement sheet pulled up right now. If you're looking at doing something even at an ASC or an office-based environment, it doesn't make sense for some of them. Even with some of the specialized cannula, $70, $80 a piece, you have to really think about where you're doing these procedures, and a lot of times a hospital-based environment makes sense, but it could be reasonable in an ASC environment if you're using some of the other larger lesion cannula. But I think to, it's very easy to just jump in and say, I'm going to do this, but you should think about, everyone should think about the financials before they do.
And also, second question for you, Scott, in terms of genicular nerve, I love, the Tran and Peng neuroanatomy. I've reviewed that myself and have changed my technique many times to make sure I try and capture those nerves. Are you familiar with any data that talks about the difference between maybe a bipolar strip lesion versus a monopolar lesion for genicular RFs?
Yeah, so I'll comment on that, and then I'll have Zach, if he knows of any. I know there's kind of a smaller Indian study a couple years back that looked at monopolar versus bipolar lesion, and I think really the big thing that they found in that study was patient comfort actually during the ablation, but there wasn't a significant change in relief post-procedure. I don't know, Zach, if you know of any other studies out there.
I don't.
The one thing I will say is I think size matters. I think the size of the lesion matters. And so if you're not doing a larger, either a bipolar, if you're using traditional, cannula, it's really important to do, consider multiple ablations, because, what we've learned in the past couple of years is there's an extreme amount of anatomic variability, and there's a robust network. And so to get them all, I even tell patients, I say, if you get 50, 60% relief, that's a huge win. It's not going to be 100%.
Thank you very much. And for Dr. Smuck, with the data, coming out with the vertebral RFA that you were mentioning, how applicable do you think this will be to most patients in real world? Because those studies obviously were very well controlled, but many patients have a mixed component or dual pathology, right? Where they have some radicular component and as well as axial component. Is there any thought process of how you think that will translate in the future to treat these patients?
That's a good question. Outcomes are only as good as our patient selection, and you can only expect these types of outcomes in a tightly controlled patient group. I do think that there might be opportunity over time for expanded indication. So isolated Schwarzer node would not qualify for enrollment in any of these studies, but there might be patients that have chronic Schwarzer node pain, for instance, or certain types of vertebral end plate deformities and fractures and tumors, perhaps, that could benefit from this therapy. So I do think there's a role for expanded indications, but I would expect the success rates to drop rapidly if the indications are not held too tightly, because it's a pretty invasive procedure. The trocar is quite large, and it's fairly traumatic because for anybody who's familiar with doing kyphoplasty and vertebroplasty, it's pretty simple to get the instruments into osteoporotic bone, but putting a larger trocar into healthy bone of a younger patient is a much different situation. And so I would expect for people without a target that would provide significant pain relief to not be too happy with the outcome from this procedure.
Great, and thank you so much. And the last question, kind of open to the whole panel, but if you have a case, but the question just came across: have any of us encountered any myositis or muscle edema after doing SI joint radiofrequency ablation? Because we talk about the posterior capsule, we talk about where we're really placing those needles and those nerves. What are kind of the risks of doing that? And have you come across significant, long-lasting myositis, edema, or even neuritis?
I have not encountered that.
Yeah, not in the sacroiliac region, not so much. So I think if you're going to have a neuritis, the most common place would be after cervical RFA.
Great. Well, thank you guys so much for your time. Thank everybody for sticking around. Our panelists are going to go ahead and step off now. I'll just get through a couple last housekeeping things for your CME credit and future schedules. So as you can see now, if you'd like to claim your CME credit, please go to the following link. You click on that link, you fill out the evaluation. And so everybody who's on this, you have about 48 hours to go ahead and claim your credit, which is great. So make sure you get this link down. There'll be a copy of this, a recording of this webinar available. So you just go there to www.danmiller, articles accreditation with that Thank you. danmiller.com activity/1921, and you can get your live credit, which is great. And you can go into the next slide. And then you can also, claim your enduring materials credit as well if you watch it on a recording. Again, the recording will have these slides available to them. And also, please go to our website at PSPS, which is the www.pacificspineandpainsociety.com, to go ahead and access these enduring materials. We have upcoming webinar series, including spinal cord stimulation, June 4th, treatment of sacroiliac joint disease on June 9th, and minimally invasive spine decompression on June 11th. Those will all have video demonstrations of techniques and surgical techniques as well. So please feel free to log on to those and claim CME credit for those as well. And then the upcoming one, like I said, is the spinal cord stimulation on June 4th, which will have a very distinguished faculty, Dr. Emma Delphin, Dr. Poray, Dr. Chakravarthi, Dr. Sheth, and Dr. Yu. And that again will be June 4th. And then there's the faculty listed for the sacroiliac joint disease on June 9th, Dr. Jameson, Dr. Patterson, Dr. O, Dr. Naidu, and myself. And then the following webinar, minimally invasive spine decompression, we have Dr. Pope. And then Dr. Leong's a surgeon, so we're really embracing a lot of surgical techniques. So we have a lot of surgeons and member of the society, so he'll talk about surgical techniques, as well as Dr. Naidu. Again, hopefully we'll have our annual conference in September. We'll keep everybody updated. Please check our website regularly to make sure as the COVID world progresses for large gatherings, as we're available to go ahead and perform that. Currently it's scheduled for San Diego, September 11th at Grand Hotel, but check our website regularly for updates on exactly how that meeting is progressing. And finally, we'd like to let people know about the Aspen CME webinar for more CME credits, which will be May 21st, hosted by Dr. Tim Deere and Dr. Dawood Saeed, President and Director of the Aspen Society. Again, those will be CME credits, and that'll be on May 21st at 6 p.m. And on that note, I just want to thank everybody for showing up. Have a great night, stay safe, and take care. Bye-bye.